Welcome to RUMC Connections. So welcome to RUMC Connections, the podcast where we spotlight innovations in healthcare and the people making a difference right here at Richmond University Medical Center. I'm your host, Meredith Gaskins, and on this episode, we're diving into one of the most exciting and life-changing areas in mental health treatment, neuromodulation, and specifically transcranial magnetic stimulation, or TMS. So we are joined by two experts in psychiatric care, Dr. Victor Mensah and Dr. Joel Idowu, to unpack what neuromodulation is, who can benefit from it, and how TMS works and why this matters. So I would like to thank you both very much for joining me today.
You're welcome.
And just to give you all a little background on them both, Dr. Mensah is a specialist in interventional treatments of psychiatric disorders at RUMC. He is a graduate of Robert Wood Johnson Medical School and trained at Mount Sinai. He brings elite expertise in transcranial magnetic stimulation, especially for treatment-resistant mood disorders. Dr. Mensah has also conducted research at the Brain Institute of the Icahn School of Medicine at Mount Sinai, focused on deep TMS and other cutting-edge therapies for major depressive disorder and OCD. Dr. Idowu is the chair of the Department of Psychiatry and Behavioral Health at RUMC, also the director of its psychiatry residency program. He received his medical education at the College of Medicine, University of Lagos in Nigeria, completed residency training in general psychiatry at Harlem Hospital, Columbia University program in New York, and a fellowship training in forensic psychiatry at SUNY Upstate Medical University in Syracuse. He is board certified in both psychiatry and forensic psychiatry for more than 25 years, and he is Distinguished Life Fellow of the American Psychiatric Association. In addition to his leadership expertise of over 2 decades, he has a wealth of experience in the treatment of psychiatric disorders across multiple spectrums. In 2019, he started the TMS treatment program at RUMC in order to offer the patients in the Staten Island community one of the latest approved treatment modality in the field of psychiatry and mental health. He has continued to hone his skills while adding and training other clinicians in order to grow the program and make it accessible to more patients on Staten Island and beyond. So let's start from the top. The term neuromodulation might be unfamiliar to many listeners. So in simple terms, what is neuromodulation and why has it become such an important concept in treating psychiatric conditions?
The way the field of psychiatry used to look or focus on mental illness and treating mental illness was from the perspective more of emotions. We have Freud and other theorists who came along with that early on, and then Prozac was invented. And since then, we've mostly leaned on both the therapy component that can treat, disorders like anxiety, depression, OCD, as well as the medication component with, so far up until TMS, the best options we had was a combination of medication and therapy to produce the best outcome. And what I will say is, if we take therapy, for example, people usually think about it as, maybe you're just venting or whatever you might have your understanding. But when we actually went and looked at fMRI scans of people who have been in therapy, you can see there is a fundamental actual change in the brain structure, which led to a new paradigm in the field of psychiatry where we're taking the brain as how do we actually affect the outcomes that we've seen in, for example, the brain structure of folks who are in therapy. How do we affect that in a shorter amount of time? And that's where the world of neuromodulation came, where we can directly impact, we can target a specific part of the brain and have that, the input or the interventions targeting that specific part of the brain that we know does a specific thing. If we can target that, then we can get the outcomes that we see that Prozac can produce, that therapy can produce in a shorter amount of time, and it's much more targeted, and it doesn't affect any other part of the body other than where we're targeting. So, lots of different modulation techniques have come out. ECT is like the original one. Then TMS, there is also a few others coming out with, high-frequency ultrasound. But essentially, the theory is this. Now in modern psychiatry or neurology, we understand, or we're able to map out specifically what every corner of the brain does, and we know what happens when you excite the neurons or cells in that particular region. So we're looking at what are some devices that we can use to excite those cells without needing somebody to take medication or do therapy for months or months. What we do is, we target a specific part of the brain, and for TMS specifically, we use magnetic photons. For ECT, uses electricity, and then something like ultrasound, uses ultrasound. So it's more of a paradigm shift in how we treat mental illness, where we're not looking at depression as maybe like a character flaw, but we're looking at it as a fundamental difference in your brain structure, how your neurons communicate with each other. And then us as psychiatrists or interventionalists, we're looking at it and thinking, what means can we use to produce the outcome? Either excite the cells in that particular part of the brain because we know what the outcome would be, or inhibit the cells in that particular part of the brain because we know the outcome will be. And then I'm going to go into more details of what each one does. But neuromodulation, in short, is more a paradigm shift, and we're just going straight for the brain as opposed to systemic, treatments of disorders.
Very interesting. So how does it differ then, from traditional treatments like medication? Is it a shorter term of treatment, or?
What therapy and medication does is try to change, the neurotransmitters in the brain, how they work. But then you have to take something, either take a medication, which could have side effects, and it takes longer to become effective. And if you have to do psychotherapy, some people are in psychotherapy for decades, and we know psychotherapy does produce objective, functional changes in how neurotransmitters work, but then it takes a while to work. So what neuromodulation does is it can do this within a short period of time. So the end product is still the same. The neurotransmitters have been impacted through the manipulation of the magnetic wave, either around the brain or some other parts of the body. For example, deep brain stimulation is also a form of neuromodulation. Sometimes spinal, they implant some things in people's, spine to be able to modulate what's going on there to, impact on their pain, pain symptoms. So at the end of the day, you are changing how neurotransmitters and other agents in the body work, but in a shorter period of time, where you achieve as much as you achieve with medication in terms of, for example, in pain treatment or psychotherapy and medication in terms of, with regards to psychiatric treatment.
Okay.
Yeah.
So walk me through it. I mean, how do we get to the point where a patient is receiving TMS? Do they get referral, and, how does it work?
I wanted to, maybe we should name, there is in neuromodulation, there was a specific neurotransmitter called BDNF, brain-derived neurotropic factor. And I actually think this could be, you can understand it simply as fertilizer for your neurons. And what we've realized is that Prozac produces maybe a little bit of BDNF, right? Therapy produces maybe a little bit of BDNF over time. But what TMS and other neuromodulation techniques can do is they can ramp up the BDNF in the shortest amount of time and keep it sustained in the blood for a longer period of time than medication and therapy. Okay. So we actually have a name for a relatively new neurotransmitter that works very differently than anyone else, brain-derived neurotropic factor. And that is, you can think about it as a fertilizer for the brain, and no other instrument produces a robust amount of BDNF than TMS. So I wanted to throw that out there too. So for someone, let's say, who isn't familiar with our clinic, if you're in our clinic already, then the easiest way to do is just to tell your provider, who would then send an email to my department. But if you're outside of the clinic, there is a direct number, and I can share the number now.
Of course.
You just have to pick up the phone and call 718-818-6693. That is a direct line to have an intake or a conversation about if you're interested in TMS. And then from that point, we will gather, whoever picks up the phone will gather some information about your past psychiatric treatments. If a patient, because it's covered by most insurances, we like to operate under the notion that our clients are going to use insurance.
Right.
And insurance has some parameters, which is you have to have either tried 2 different medications in the past that didn't work, or a medication and therapy. Those are, the quickest sort of screen in, screen out. And then once you provide your past history and you've been in treatment and you do fit, let's say you've tried 7 different meds at the high end, or even just 3 in therapy, we deem you to be appropriate, then, you submit a medical clearance. You should see your PCP. Sometimes there are reasons why somebody can't get TMS, like if you have an implant in your head, for example, or some other, seizure disorder is a major one that screens somebody out. But if you don't have any of those issues and your primary care approves it, then we bring you in for a 45-minute visit where you'll likely be seeing me. I'd like to do, the screenings. I'll have a conversation, 45-minute interview, determine if you're appropriate, then we'll get prior authorization. And we do all of that.
Oh, great.
Basically, up until now, with someone interested, all you've done is pick up the phone and call my buddy, Jay. And that's it. We handle everything from there. And then once we get the prior authorization, you get called in for a mapping visit. And then from there will be whatever protocol we decide to go with for you. And, we'll get into the details of the different protocols and what we have available for clients.
Yeah, we also have alternative numbers that you can call other than the 6693. So we also have 718-818-5777, which goes to our front desk staff. Also, the director of the outpatient programs, Randy Davis, is also sometimes receives the calls.
Okay.
So that number is 718-818-5276. We want to give patients opportunity to be able to, to locate somebody who will take their referral, and then we will take it over from there.
Perfect.
And there are also insurance plans that doesn't need prior authorization. So if you're on Medicare, for people who have Medicare insurance, they don't need prior authorization, but they may need for their secondary insurance.
But it's helpful for people to know that it is relatively new that it's being covered by insurance.
Right.
And I think if more people knew that, just come in, give us a call, we'll carry you the rest of the way. Worst case scenario, we come back and tell you your insurance doesn't pay for it.
Yeah.
Right? But most insurances do. And if you're interested, just pick up the phone, give us a call, and we will run with it the rest of the way.
Okay. And, let's walk people through maybe what it's like to actually get this treatment. So they come in, is something being placed on their head? How does it work?
Yeah.
Debunk some myths, because I'm sure some people could, be fearful that it might be painful or, something like that. If it's something foreign that they're not familiar with.
Right. And I know when people hear about TMS, sometimes they confuse that with also the existing treatment, ECT, which ECT has been around for decades.
Yeah.
And it's an effective treatment, probably one of the most effective treatments we have in the field of psychiatry, especially for people who have depression, other psychiatric disorders, or something that we call catatonia, which is when somebody is not really responding at all, and they may almost look like they were sometimes like, I don't even know, paralyzed might be the best way to describe that. So you get a very quick response from the ECT. ECT is more invasive procedure because it involves electric shock, electric current. TMS is completely different from that. So we want to kind of clear that myth out there that it is not the same as what people call shock treatment.
Okay.
This is a magnetic stimulation, which is using the magnetic wave around the brain to really do what it needs to do to the neurons that will then further stimulate the BDNF and other neurotransmitters to achieve improvement for the most part, remission of symptoms. So the first visit is after they've seen Dr. Mensah or any other psychiatrist in the clinic for the initial 45 minutes to 60 minutes consult, in getting their screening and their information and all that. Then the next appointment is what we call mapping.
Okay.
Mapping is where we do the initial, you could call it measurements of what type of, what is going to be the person's parameters for treatment. So that might take something close to 60 minutes, to get all the numbers right and make sure we locate the proper place to apply the treatment for the person, for that treatment to be effective. So that's the first visit for mapping. And then after mapping is done and we know what the parameters are, the subsequent visits are very easy. It's like 20 minutes to 30 minutes. Oh. You come in, you get your treatment, and you're good to go about your business for the rest of the day, which is also a big difference also from the ECT. For ECT, you get anesthesia. Okay. And then you may need a period of recovery. Wow.
Gotcha.
In TMS, there's no anesthesia, there's no period of recovery, you get treatment, and you're good to go. The most common side effect, if you want to call it that, is maybe a mild headache, usually in the first few sessions of the treatment. Most people get used to that over time in response to simple Tylenol or Advil, once you leave. Like we said, contraindications, some conditions that will make you not be suitable is if you have an implant in your brain or you have a history of seizure disorder. You will not be able to do anything, any matter above your shoulder, it's going to rule you out of being able to receive it at TMS. There is, I guess, 1 in 1,000 risk of having a seizure disorder during the procedure. We have not seen that since we started in 2019, so it's not very common. But there's a risk to everything.
Of course,
so this one
everything has a risk.
A minimal risk of 1 in 1,000.
The newest paper actually is 1 in 30,000.
Okay. So it's actually getting
even better. The newer studies are when you isolate people with a history of seizure disorders, you're normal person without a family history or anything. It's 1 in 30,000 of seizures. So the risk is very, very low.
That's great.
And I usually think about it as it'll either work or do nothing, and then worst case scenario, you try something else as opposed to, if somebody is coming in, either if they've tried a bunch of meds and it hasn't worked, or just wanting something different. A headache, I think, is the worst.
Yeah, I think the headache is actually the worst thing that people experience.
But it's a great kind of wake up and go. Like we even have people who come in before work to get their TMS, and then sit there, get it, and then go to work.
People have to go to work. We schedule them for 8 a.m. TMS. They come in, we do the TMS, 8:30 they're out.
And how does it work? Is it something that people receive as a treatment for several weeks, months? Do you do treatment for life? Or
I'm going to take this one. So there is the TMS application in research has actually been around for almost 70 years.
Oh, wow.
So what is out there that is covered by insurance currently, most of providers who use insurance do the 30 minutes, 5 days a week, Monday through Friday, and then for about 6 weeks.
Okay.
So currently that's what most folks can provide. In the newer iteration of this machine, we've managed to be able to essentially, the newer machines, which I actually believe we're getting the newest one very, very soon, we managed to take that 30-minute stent for you to get one treatment, able to bring it down to within minutes. There's a newer frequency called theta bursts. And the theta burst is able to deliver the same amount of TMS that you would in 30 minutes in about 3 minutes. So moving forward, when you ask the question, how long is somebody expected to do this? Different providers have different parameters that they use. And currently, most of us are stuck in the 36-session, 6-week sort of paradigm. But my research was actually in the theory of trying to shorten to stay. Because I think in the next 5 to 10 years, everybody's looking to go to the newer models. There's a new parameters called SAINT protocol that can achieve the same outcome that you do in 36 weeks in 5 days.
Wow.
So that's actually the goal that we want to target. There is one caveat to that the challenge now is how to make the response last longer.
Got it.
Best outcomes are able to go out 6 to 8 months, maybe a year of remission before the symptoms come back. So that is one part that as researchers are working on. We still need to optimize that bit, making it last a little bit longer, but with the immediate effect of getting somebody from a 90% depressed to not depressed in a week, we're there.
Wow.
We actually have that technology.
Yep.
It's a matter of, so far, insurance doesn't quite cover that level, but we are heading towards the 1 week treatment of major depressive disorder. That is my personal, goal.
Yeah.
But that's where we're going. Eventually, we want to get to a 1 week treatment
That would
of
be
major
amazing.
depressive disorder and OCD. But that's
So who
a
else is a
long-term
good
goal.
candidate for this?
Yeah, just before, there's also another protocol that, the people who manufacture the equipment that we're getting, the newer one, also are developing, which is not 5 days, but it's still a lot shorter than 36 weeks. It will be about within 10 days that you can actually do every other day, or you can do the 10 days consecutively if you want, giving about 5 treatments every day for 10 days.
Wow.
And then you can do that that's about less in 2 weeks at the most. And then you can follow up with maybe a little maintenance treatment, once every week for another 4 weeks or something, to do that. So that's also another modality that's out there now that is, we're planning, looking into. But our goal really is to go to the most effective protocol in the shortest amount of time. That's what we're aiming for. So that way we can serve a lot of people that will need this treatment going forward.
And to address your question of who is this ideal for, it is actually interesting. We have a lot of older patients in our current clinic. Most of what the research is showing is, and if you think about the theory of neuroplasticity, says that a younger brain is more likely to accept the changes that are naturally going to happen with TMS than an older one. But so far, I believe everyone in our clinic so far has been above 65, and they've all reported remission and, or fully, treatment at the end of their sessions. So ideally, the younger the brain, just because the malleability of a brain, a younger brain is more malleable and open to new ideas than an older one. But we've also seen it work for, people of all ages as well. So
No, I think also it's good to know that even in the research that were done, no age group was excluded. So it's been effective across all age groups, in adults.
Okay.
And the good news is recently, FDA just approved it for the adolescent population as well for treatment of depression.
Okay.
So that's also something that we're looking into, possibly offering the younger population.
Yeah.
FDA, we're allowed to treat up to 15 years old
15 years.
now.
Okay.
Which I always imagined was actually the thing that stimulated my interest in this. Is the pediatric population. I actually believe why not try TMS first before giving a 13-year-old girl a medication that will change her hormones and things like that,
Yeah, and there's several reasons to do that. That's one thing is, you give people medication at a very young age, it can actually change their chemistry and their hormones in a very significant way. Younger people also don't like taking medications because they're concerned about so many things, the weight gain, the change in, of course, the stigma, all of those things. So if they can receive something else, other forms of treatment that doesn't involve, medication that changes their chemistry or their, biology, I think is a positive thing for them. Yeah.
Okay. And you've both mentioned this being successful for depression, for OCD. Is there anything else that this is a really good treatment for?
There are indications also, already approved by FDA for tobacco cessation. Nicotine, as we know, is one of the hardest substances to give up. That addiction is probably worse than addiction to alcohol, cocaine, and other substances. People who smoke for many years have difficulty giving it up. FDA has approved TMS as treatment also for tobacco cessation.
Okay.
And it's been known to be effective. We looked into doing that a couple years ago. We haven't started that yet, but it's something that we might look into the future. So tobacco cessation is approved for that. They also other studies being looked into include even medical treatments like MS, multiple sclerosis is ongoing. I don't think we have the approval for that yet.
Neuropathic pain.
Yeah, pain, even autistic spectrum disorder has been there's been reports about TMS being beneficial in patients who have autistic spectrum disorder.
Okay.
And movement disorders, Parkinsonian.
Yeah.
I mean, because it's the theory is we have fully mapped the brain. We know where everyone does. So if we know how to specifically target a region of the brain and we know what excited cells do, target that region, excite the cells, produce the outcome you're looking for. Okay. So from that paradigm, you can really go anywhere you want with it. But we are currently limited by, even though there's FDA approvals for about 6 conditions, insurance is only covering one.
Effectively.
Not even OCD.
Right.
Insurance is not even for anxiety. Insurance is only covering for MDD as it stands. I think with the flood of papers that are coming out this year and the next, that will change. But currently, the insurance is only covering for major depressive disorder. But that I imagine will be changing very quickly.
Sounds like it could be very helpful for many things.
Yeah. I mean, the addition to that is that because we know for each disorder where the problem is in the brain. So what TMS, strives to do is localize that area, and that's why we do the mapping, because the mapping helps us to sort of localize the area. We know for depression that the problem is in the area that we call left prefrontal cortex, is where the problem is. And if we do, a study we call PET scan, which is positive emission tomography, and it kind of maps out the brain. It looks mostly at the blood flow. Blood flow is important to how our brain functions. People who have depression especially have poor blood flow in that region of the brain.
Okay.
So what TMS does is, as it works on the neurons and the neurotransmitters, it helps to improve that blood flow. But we have to be able to sort of target that area. And we'll do the same thing for people with Parkinson's or with MS and other conditions. So it's different regions of the brain are targeted for each specific disorder.
Very interesting. Yeah. So it's all just kind of, done through this mapping process and then targeted. Okay. So I'm assuming that, this will really help improve, behavioral health equity and access for Staten Island residents to know that they could receive this sort of treatment on the island and not have to go to Manhattan for it.
Exactly. We live on an island, and Staten Island is really an island in the true sense of it. Yeah. We have 4 bridges that surround us, 3 to New Jersey, 1 to Manhattan, and then we have to take the ferry. Or I always joke sometimes, unless you can swim across the Hudson River, No, but seriously. So, and we don't have a lot of, we have only 2 hospitals on Staten Island for 500,000 people. Yeah. We really need more than that in the ideal situation, but, it is what it is. We are fortunate that we have a lot of behavioral health services at RUMC. We provide about 2/3, even more than that sometimes, of behavioral health services on Staten Island. So we're the leader in that field, and we have to continue to expand our services to be able to reach, as many people as possible on the island. Not only that, but also bring in new services, new treatment modalities that Staten Islanders can benefit from. And this is an effort towards that, goal.
Absolutely. Yeah.
And I think, the equity part, I think, is TMS is covered by insurance now.
Yeah.
Right. I think that was the moment for me where it stopped becoming something for rich people. Because when I started my research in it 3 years ago, the only people we were servicing were people who were able to pay $15,000 out of pocket for a 6-week treatment.
Wow.
Count I don't know how many people you know who can do that, but that is, now that it's covered by general commercial insurances, I think now we're only limited by the capacity of how many patients we can get started, and then the providers to actually deliver the TMS. So I think if there's nothing else I want to add today, TMS is covered by insurance. It won't hurt you to just pick up the phone and call. And then let us do the rest.
Absolutely.
And if you have tried other things and they didn't work, this is one option. And in the research that's done, the remission rate is anywhere from 70 to 80%. And when you compare that to the remission rate for medications being 30 to 40%, the best medications only gives us 30 to 40% remission rate. And when we say remission, is somebody who is completely free of symptoms. It's only 30 to 40% with the best medication that is out there. Meanwhile, TMS gives us 70 to 80%.
It looks like the future is bright then for TMS.
It's a big plus.
Wow. It seems like it's just kind of the tip of the iceberg for what this can do, and that it has a lot of potential to help many people with different conditions. So it'll be interesting to see how this evolves, and it's wonderful that RUMC can offer something like this to our community. So I would like to thank you both for this eye-opening discussion. If you're listening and you want to learn more about TMS at RUMC or schedule an evaluation, you could visit our website at rumcsi.org, or you can call the numbers that they referenced earlier, 747-818-5777. Thank you both for joining me today, and that about wraps up this episode of RUMC Connections. So feel free to subscribe, leave a review, and share this episode with someone who might benefit. Until next time, I'm your host, Meredith Gaskins.